and also all our participants who have joined us today for the webinar, Access to Medicine for Hypertension Care and Control. Now I request our patron, uh, Professor Meenu Singh Madam, for a keynote address. Over to you, ma'am.
Okay, thank you. Thank you, Nandita. I will be talking a little bit about hypertension because this meeting is about access to medicines for hypertensive patients. And it is a project which is part of our global health initiative for global health advocacy initiative, which is there. And Dr. Pradeep Agarwal is very, very efficiently managing that incubator, in which we have to provide health education as well as care packages to patients suffering from different kind of diseases, and especially diseases which have something to do with nutrition. We know that nutrition has to do with all the diseases, and Dr. Pradeep has been working on front of package labeling under this project, which has actually become a very, very important issue with the government. And it is something which we need to take up at all levels, that all foods which are being consumed by human beings, and they should be labeled with their composition, and people should be able to know what are the possible harms or benefits of those food items. Now, for hypertension, we know the salt content is extremely important, and the foods that we consume, their salt content is extremely important, and it will be good to know that, on the top of all the packets that the children and adults are eating of all these fast foods called wafers, chips, and, all the things which are there, uncle chips, we need to really put it on them how much salt you are consuming and how many empty calories you are eating. So that is something which is very important as a preventive aspect. But now coming to the curative aspect, we know that hypertension is a major health concern in India, and it is affecting a very large proportion of the population. And according to National Family Health Survey, NFHS 4, which was conducted from 2015 to 16, the prevalence of hypertension among adults aged 15 to 49 years in India was 11.3%, which is a very large proportion. But another disconcerting fact was, which is a more recent estimate of the Comprehensive National Nutritional Survey, which is conducted from 16 to 18, it has indicated even a higher prevalence of hypertension of around 22.2% amongst adults of 18 to 69 years of age. We know that as the age advances, the prevalence of hypertension increases. And we had actually in Chandigarh, we had done a survey of about 3,000 people way back about 10 years ago. And we had found that in the middle-aged group, about 45% of the people were qualifying for the diagnosis of hypertension. And it was associated with obesity. It was also associated, of course, with high stress environment of people who are working in those kind of jobs. And so it's a very, very significant health burden that we have. And we have this NCD Federation, which is based in Department of Community Medicine in PGI Chandigarh, where Dr. Thakur is looking after. And they had also come out with very large disease burden, which is because of hypertension and its related problems, which is coronary artery disease of the heart, as well as its effect on the kidneys and the renal failure, which ensues all these problems. So they constitute a very big burden. So if hypertension is treated right in the beginning and early and completely, then we can avoid all these complications. And we know that treatment of hypertension is just simply, one is, of course, prevention of foods which have high salt content. but also your lifestyle modification. But along with that, drugs are important, pills are important. And because with that, you actually control the higher blood pressure and bring it down to the levels which can be then taken care of with the help of lifestyle modifications. But we know that medicine availability in different areas is difficult. And or even if we know that an intervention works, that a drug treatment works, it is not available to all. It is something where, the translational aspects of research, that we are not able to take the interventions right up to the community, to the last person who's suffering from these diseases because of the access problem, because either people don't have money to buy these medicines, or they are located in such places where these medicines are not available as a continuous supply. And sometimes they have to travel a long distance for getting medicines. Now, we are telemedicine people. We do a lot of telemedicine interventions as far as diagnosis is concerned, and consultation with patients is concerned, and counseling with patients is concerned. But, in telemedicine, it is okay that you're talking to them, you find out about the disease, but you are not able to monitor them. But of course, you can monitor them also continuously if there is a person who's there on the other side and monitors the blood pressure of the patient. And there are so many devices which are now available, which are point of care, which the patient themselves can monitor themselves and inform the doctor about the values which they are getting, whether they are of blood pressure or they are of blood sugar. So these interventions are something which are really helpful. But then, in spite of all that, you can't give drugs to these patients, because ultimately, if the blood pressure fall is related to a particular drug, in that case, we have to make that drug available. And we are very happy to say that we have come out with a technology in which drug delivery also is now, or access to drugs is also something which we can fulfill. And that is through the drone technology. We at AIMS Rishikesh have started a drone service, which is right now primarily for TB patients, in which we are trying to give TB, anti-TB drugs to patients, and also take samples back in the drones from these families, because many times tuberculosis is affecting the entire family, and some people have infection, some people have disease. So all that has to be categorized if we have to eradicate tuberculosis. But I think the similar intervention can be done for hypertension and diabetes. For these chronic diseases, when patients are located at sites which are very far off from hospitals, we can deliver them medicines. First, we need to make a telemedicine contact with them. We need to know their actual geotagged address, and we can then send them medicines through using the drones. At least in the state of Uttarakhand, at the moment, we can cover the entire area, and we can send medicines to these patients. It is just that they have to be picked up. And for that also, we have a system of drone DDs, which actually come out from that community. And one of the patients can actually act like a drone DD. And they take out the medicines, and those medicines can then be distributed, in the villages, wherever the patients are. So what we need to do is to actually find the location of our patients. So say at AIMS Rishikesh, if we have 100 patients of hypertension located in different districts, at say in villages, that is where these medicines can be delivered. So I would actually request the state administration and NHM to actually practically look at this particular model. And I was thinking of linking our Jan Aushadhi, because that is where you get cheaper medicines, and we can send these medicines to these patients. Because as far as anti-TB drugs are concerned, they are given for free. But medicines which are related to diabetes, hypertension, for that, there is no provision that they can be sent for free to these patients. And hence, we need to link it up to some system, and so that these drugs are available and they can be sent for free to these patients, because they have to be taken lifelong. And there is a very long commitment. For TB, it's only 6 months, but for hypertension and diabetes, I think it is lifelong. So for that, I think we need to set up some kind of consultative group in which we decide how we are going to implement this model for non-communicable diseases, because non-communicable diseases are actually becoming a very big burden. And as we know, India is reeling under triple burden of disease. We have communicable disease, we have non-communicable disease, and we have a mixed burden which is there. And that is going to affect the health of people in the future to come. And these days, we are talking of what is known as value-based medicine. And so it is not just evidence-based medicine. It is not just what has come out in randomized controlled trials or in various studies. It is also the human values which are associated with this, because we also must look at the economics of medications and also offer patients drugs which they can afford. Secondly, we need to have access to medication. That is what we are addressing by improving our transport service and getting the drugs to the patient's doorstep. And thirdly, it's also a question of equity. We know that poor people have, poor access to drugs. And even in rural areas, although the prevalence of hypertension is a little less in rural areas, but in some areas we had worked actually in Haryana, and we found that in rural areas of Haryana, it was as high as in the urban areas. And I think it was somewhat similar in Punjab also, because there also prevalence of obesity was somewhat similar, because now even in rural areas, the lifestyle has changed, and they are no more rural areas in that sense of the word. People have all kind of amenities, and hence these people also need to be catered to, and their values and their attention to these to their self-care and health-seeking behavior is something which is very important, about which we must educate them. So I think these are some of my thoughts on the current the current topic which is being discussed. I think I have finished my time. So it's really a very good initiative, and I request Dr. Singh and Dr. Arit Kaur to keep guiding us, and also Dr. Gurman Sekho, who's joined us from Punjab. And I'll be very happy to whatever we can offer as a support from All India Institute of Medical Sciences, Rishikesh. Thank you. Thank you very much. Jai Hind, Jai Bharat.
Thank you so much, ma'am, for enlightening us and also for enlightening everybody that AIMS Rishikesh, under your able guidance, has started with the drug delivery system for delivering through drones for tuberculosis patients in the region of Uttarakhand, and also for highlighting the role of drone Didi, which can be utilized for not only providing medications to the TB patients, but also for non-communicable disease like hypertension and diabetes. Now, I would request our chief guest, Dr. R.K. Singh, who is the director of NHM Uttarakhand, to kindly take over for his topic for prevalence of hypertension and drug delivery system, which is currently in practice in the state of Uttarakhand. Over to you, sir.
Thank you, ma'am. Thank you, ma'am. First of all, a good morning to respected director, ma'am, AIMS, and all the faculty and our guest in this webinar, and including our audience. As previously, director, ma'am, engaged some the topic of the hypertension prevalence, how drug delivery is taken by our in Uttarakhand health systems. First of all, I elaborate to at that moment, we have the 1808 Ayushman Arogya Mandir, and in Ayushman Arogya Mandir there is a posting of the CHO, and there is a 1362 subcenter are upgraded as Ayushman Arogya Mandir, and 408 PSC upgraded as a Ayushman Arogya Mandir, and 38 UPSC. So now at present we have the 1808 Ayushman Arogya Mandir. In Ayushman Arogya Mandir, there is a screening of the NCD, non-communicable disease, which is the diagnosed by the higher centers like CSC, district hospitals, AIMS, or any other higher health systems. And when they come back to their native place, so there is a Ayushman Arogya Mandir in which our CHO are continue monitor the BP of that particular person who is suffering from the high blood pressure or hypertension, and they provide drug to that particular person. our CHO are enabled to elaborate and they increase their drug demand by e-Aushadhi portal, which is at present in Uttarakhand. DBDMS, they direct demand their drug for their locality of the hypertension and diabetes also. In this hypertensive, they continue monitor and these patients, and they also some basic test, pathological test. They have the and our Ayushman Arogya Mandir are situated near about 5 kilometer, every 5 kilometer, near about Ayushman Arogya Mandir is there. By which ma'am elaborate to the diet and the lifestyle changes. So in our Ayushman Arogya Mandir, our CHO are doing the yoga sessions week and fortnight, and they also give the advice to the that particular person who is suffering from the blood pressure or hypertension for their diet also, and they continue support to these type of patients. I have some data of our NCD non-communicable disease, just like hypertension and others. In 2021, there is a footfall of 18,905, and nowadays 2023-24, the footfall is the 4,81, 48 lakhs 18,199. So, sir, there is a large support by our Ayushman Arogya Mandir, and our CHO are already used doctors are situated in our centers, sub district hospital, and they continue with the help of the mobile or tablet. They continue support to the patient. At present, in if I'm going to the our data in 2020-21, there is a 58,977 teleconsultation. But in 2023 and 24, these data 5,88,869. So they continuous going to our field for the diagnose this particular patient and continue support by the providing the essential drug for the hypertension. If there is any issue or any problem with that particular person, they continue support by the teleconsultation with the specialist doctors presented in our telemedicine centers. So by this way, in Uttarakhand, at present, there is a drug delivery system from the state to the district, and from district to the CSC, PSC, and the Ayushman Arogya Mandir by raising their demand on the e-Aushadhi portal. So by this way, we have continued support to that particular patient, and also by the change of the lifestyle, just like yoga and their diet advice. And I also invite and also to the AIMS faculty and director ma'am, they support to us our how can also improve our these Ayushman Arogya Mandir in which our CHO are posted. At present, near about 82% Ayushman Arogya Mandir are filled by the our CHO, and some there is a 200, I think within a 10 to 15 days, these all Ayushman Arogya Mandir are vacant posts are filled up. So by we have continued support from CSC and PSC. There is a doctor's medical officer, but in a rural area, there is a CHO. They only monitor and teleconsultation or advise, or they call to the PSC doctors or CSC doctor for the patient condition and advise regarding and giving the drug to the that particular person affecting from the hypertension. So by this way we have a chain of the drug delivery system from state to the village level at our sub-center level, which is our nowadays Ayushman Arogya Mandir. So by this way, we have continued support and treated the hypertension patient in our Uttarakhand. So and continue demand, they generate their demand for the essential drug to the ESRD portal and DBDMS portal, which is a system I will know about our DBDMS. That's in which Ayushman Arogya Mandir there is a shortage of the drug or any relapse to the are the essential drugs of the hypertension. So by this way, we also demand to these AIMS faculty and director ma'am are supporting us if they analyze our Ayushman Mandir or further any. Thanks to Dr. Pradeep Agrawal for inviting to us. If any query regarding this, so please. Thank you.
Thank you so much, sir, for telling us about the current practices and the prevalence of hypertension care and control in the state of Uttarakhand. Now, I would request Dr. Arit Kaur, who's the former director, former director in Punjab Health Services, and Dr. Gurman Singh, who is a lead consultant in Punjab NHM, to kindly share the best practices of hypertension care and control which they had undertaken and for which their achievement was lauded not only in India but also worldwide. Over to you both, ma'am and sir.
Thank you so much. Thank you so much for inviting Punjab. And I'm grateful to you all. And I would, because I'm no longer working with the government, so I can just talk about how we started the project and the details of the project, and the present scenario will be put up in a PPT form by Dr. Gurman. Dr. Gurman has been, like, he and me have been a team throughout. So when we started this project in 2019, at that time, I mean, we started in October 2019. Prevalence of hypertension in Punjab is much more than the national average. It is like about 15 points more than the national average. We are like looking at up to 40% prevalence of hypertension in Punjab. So when we started, there were 2-3 issues. The pillars of our program were, first, the public awareness part, because why we have hypertension. I mean, we are hardworking people in Punjab. Why should, I mean, our food habits are like that. But as far as food habits of the of people are concerned, we are also to be blamed, because we, the educated people, because we, when I was a child, we were somehow told that desi ghee is a very bad thing, so bad that we used to, like, I never have ever had desi ghee in my life, because we thought it's very bad. At 40 years later, we learned that desi ghee is not all that bad. It is safe. Like, our mothers make it from the malai of the doodh, and then the butter, and then the desi ghee is made. It is the palm oil which is bad. So, like, we have to not only undo whatever we knew so far, we had to tell our people to start new practices. Like we always thought to have a biscuit is very fine, because it is like sterile, it is nicely packed, multinational companies making biscuits. But how many calories, how much salt, how much trans fat we are consuming with each packet of biscuit, or with each packet of chips, we never thought of all these things. So all this information which came to us at that point of time, we had to share with our cadre. And who was our cadre? Our cadres were like very proudly, Punjab had introduced about 2,600 health wellness centers at that time, which they were called. And we had a community health officer working there. So, community health officer working there, I think, is a very good initiative, because our MBBS doctors are worth much more than, sitting in a small village and seeing up to 20 patients a day. I think that would not be the ideal thing. To have a community health officer in a small place is a good idea, because a community health officer can look at a range of services. So first thing we started with was the awareness part. So we had for our community health officers lot many awareness workshops, and gave them literature to be distributed at the centers and to be displayed, the banners and posters about food habits, trans fat, and about hypertension, diabetes, exercise. That was one part, the awareness part. Because it's tragic that we got aware very late in life. So when we got aware, we tried to spread it as much as we could, with the help of course, the other organizations like GHAI. And the next part was, when we started, then COVID stuck in 2020, early 2020. And we, in villages, we had our CHOs. So we needed to establish telemedicine services. And very proudly, I would say that March 2020, we set up our telemedicine hub, and we started doing telemedicine services, which came to so much use during the COVID period, during the lockdown, when people could not travel long distances to get the medicine. Our centers were open for 12 hours a day, even on Sundays, so that people could come and collect their medicines, especially the hypertension, diabetes, TB medicines, which were a must. With the establishment, before telemedicine hubs were started, we had started a model called Kalanor model, in which because community health officer cannot write prescriptions, so we had a plan that every month there would be a camp in the area of each health wellness center, where Asha and ANM would collect all the suspect and already taking medicine patients of hypertension and diabetes. A doctor would visit and write the prescription. So, and at that point in that camp, there was a provision to check the blood pressure, of course, and also the blood sugar levels. So the doctor can write the prescription, which the CHO can carry forward. But with the establishment of telemedicine services, and then we also had specialists, especially gynae and medical specialists in the center, doctors to guide. So that system was set up. So this part was covered. The other part was the logistics about the availability of the drugs. There were multiple problems there. So because in the government sector we go by the tender system, so sometimes telmasartan would come up as an antihypertensive drug. The other time it will be metoprolol. The other time it would be amlodipine. So a patient already on a long term drug cannot be switched from one drug to the other just like that. The other thing is, for the whole state, we have still four warehouses from where the drug comes. So the drug has to be collected from the warehouse, and there were no designated vehicles also which we could find. So a PHC goes and collects the drug, then from PHC to the community health center, bringing health wellness center to bring those drugs is another challenge. Our ASHA workers, and we had photographs also with the boxes of drugs which an ASHA worker is carrying on her moped, because there was no delivery system. So we thought of a delivery system. We had a designated van, which would go around all health wellness centers every quarter of a year and deliver as per the demand the drugs. So we with great effort, we chalked out how much drug a center could need, and how it can be distributed to each of the center in a quarterly basis. So these are the things which we want, which were the ideal situation, and to achieve that situation we really worked hard. Now how it started, whatever is happening, I will request my very hardworking and intelligent consultant, Dr. Gurmandeep, to present before you. Thank you so much.
Thank you, ma'am. Thank you so much. Good afternoon, ma'am. Good afternoon, everyone. I would like to thank AIMS Rishikesh for this opportunity. So today I will be talking about basically how we strengthen our primary health care, that is through HWCs, as already told by Dr. Zadeep, as well as through Aam Aadmi clinics, and what activities are we are undertaking there, and then how we strengthen our last mile delivery of drugs basically to these centers, to HWCs and Aam Aadmi clinics. So I'll share my PPT. Is my PPT visible?
Yes, sir.
Okay, thank you, Ji. Thank you. So as Dr. Reeth has already told you about the briefed you about the basic activities or the interventions which we have carried out, both the schemes were started under the guidance of Dr. Reeth only. So HWC were started in 2019. Currently, we have 2,400 sub-centers operational as HWCs, with having 2,400 CHOs at these centers. For Aam Aadmi Clinic, we have a network of 842 Aam Aadmi clinics in the state. These are basically 530s are in rural areas, whereas 312 are in urban areas. Here we have a standardized, basically standardized care. We are giving 80 type of medicines and 30 type of diagnostic tests are being carried on a PPP mode at these Aam Aadmi clinics. And these are basically the paperless clinics where we are using IT infrastructure for the prescription, dispensation, as well as the registration of the patients. So how the continuum of care is being maintained at HWCs and Aam Aadmi Clinic? At village level, Ashas are doing the risk assessment through CBAP performers. Then the CHOs are doing at HWC level, sub-center level, they are doing the screening, diagnostics, telemedicines, drug dispensations. And at PHCs and Aam Aadmi Clinic level, the final diagnosis for the NCDs are being done, and then the prescriptions are being written at the PHC and Aam Aadmi Clinic level. And for the advanced diagnostics, the patients are being referred to the CHC as well as SDS and basically secondary facilities. Then these are the how we are doing NCD screening basically at the HWC level. First of all, CBAC performer, that is community-based based assessment checklist, is being filled by ASHAs to prioritize the risk population. Then the people having the score higher, more than 4, are being mobilized to HWCs for the screening of hypertension. Then the hypertensive patient are being put on medications through teleconsultation, or as well as from the MO of Aam Aadmi Clinic or a PHC. Then these are being referred back to HWC for the follow-up, and as well as for the dispensation of the drugs. And if the patient is non-hypertensive, health promotion activities are being undertaken. Then these are the already, as told by Dr. Lee, the camp-based approach being used at HWCs, that is NCD screening, where we hold camps, village-wise camps are being organized every month, where the medical officer has been deputed just to write prescriptions as well as to confirm the diagnosis. At these camps, the role of Asha is to mobilize the crowd to these camps, and treatment or medicine of 30 days for hypertension or diabetes is being given on the spot. And the data is being put on the CPHC app, NCD app, as and then the telemedicine, already told by Dr. Reed, it is available at 1,570 HWCs. We have 6 telemedicine hubs and 19 medical officers, and now we have 3 gynecologists at these telemedicine hubs. So these are the prescriptions basically of hypertensive patients being written from the telemedicine hub. And these are the basically treatment, how the IHCI protocol is being followed at all the HWCs, and even the MOs of Aam Aadmi clinics has been trained for this IHC protocol, that hypertension protocol that we have adopted. CHOs are also making awareness regarding the healthy eating habits, how to cut down the salt and avoid the use of alcohol or tobacco. Then the physical activities which are being undertaken at HWCs, that is the wellness sessions. Then also we are focusing on, as we have a high MMR in the state, we are focusing on pregnancy-induced hypertension also. So it is mandatory for all the HWCs to done a teleconsultation with a gynecologist at a hub of every high-risk pregnancy. Then this was a campaign regarding the trans fat use, which was done by earlier in the 2022, just to eliminate trans fats. These are the wellness session. Till date, around 6 lakh wellness session has been conducted at HWCs. Every HWC is conducting 10 wellness session every month. So what was the issue? Issue was related to the drug delivery, basically. What are the objectives of primary health? We all know that it is availability, accessibility, and affordable healthcare services which we have to provide at the primary healthcare facilities, basically. So what was our issue? Basically, it was a deficient supply chain management. Basically, a supply was an issue. So what are the intervention that we have done? First intervention was the evidence informed demand forecasting forecasting of drugs. Basically, earlier what we used to do, that we used to forecast based on the past purchases, not on the actual consumption. So by this approach, we were discounting the factors like stock out days or unutilized stocks. So what we have introduced a management information system at Aam Aadmi clinic level as well as HWC level. Now all the drug dispensation is being done through MIS system only, and even the demand is being raised from Aam Aadmi clinics to the warehouse through this MIS system only. So by introduction of this system, we are able to maintain 3 months stock level, and even no stock outs have been reported during the last 6 months. Then the other was the timely and adequate procurement. Earlier issue was we have a limited supplier diversity, reliance on one-time tendering. Basically, the solution, we have introduced the clause for order sharing with multiple bidders. Like what we are doing is we have introduced a clause of order sharing with the lowest, second lowest bidder as well as the third lowest bidder. If we want to supply the drugs on L1, so by this way we are having multiple suppliers at one time to cater the excess demand of our facilities. Then also we have created a monitoring tool for rate contracts, that which rate contracts are expiring, when they are expiring, when we have to do a new rate contract, all that stuff. So over 90% of the required drugs have an RC today as of date, and faster turnaround for a drug restocking. Basically, this is an impact of this intervention. Then quality checks. Earlier, what we used to have, we have only one lab. Used to had only one lab, so there was a heavy burden on a government lab, causing delays in the delivery of the drugs. Basically, so now we have impaneled 6 private labs for the basically quality testing, so that we can test the drugs as soon as possible, so that they can be delivered to the health facility. So due to this, due to the empanelment, new 6 private labs, the turnaround time reduced from 30 days to 14 days. So there is improvement in the drug availability at primary health units, basically. Then the digitized inventory management, as already told you, the Aam Aadmi Clinic is already paperless, and even at health wellness centers, we have introduced the e-Shushruth app for the registration of patient as well as for the dispensation of drugs. So at Aam Aadmi Clinic, uh, we know that which drug is expiring on which date, and which drugs which drug we are going to have a stock out of which drug in next 10 days. So they are basically making demands on online only before the stockouts. So this results in 60% reduction in the drug expiry. So they are using FIFO mechanism. Then the transport, already told by the complex, there was a complex supply chain with increased transit times. Then we have engaged, already told by Dr. Deet, we have engaged private partners for a dedicated transportation fleet. So this has reduced our time, that is fulfillment time reduced by 38%, that is from 44 days to 15 days only. So this was our impact. That is, all the essential medicines improved from 48% to 100%. Earlier, 92%, 92 medicines were to be supplied. Only 48 were available. 48% were available. With the introductions of these many interventions, all the 84 essential medicines are now available 100% at Aam Aadmi clinics as well as HWCs. And this is the increase in the OPD after the drugs are being delivered on time. Due to the continuous availability of drugs, there is a sharp increase in the OPD's footfall also. So that's it from my side. Thank you very much.
Thank you so much, Dr. Areet and Dr. Gurman. That was very enlightening. The best practices followed by the state of Punjab under the leadership of Dr. Areet ma'am and Dr. Gurman could applied not only in Uttarakhand but in India. We could see that how not only they took the help of technology, that telemedicine, and better help to better access the medicines and increase the OPD, and for controlling of non-communicable disease like hypertension and diabetes. Now we would like to show a patient story of a patient, how the timely intervention helped him to heal himself and lead a healthy life, which we have covered, a patient, hypertensive patient story.
Dr. Gurman, please stop screen sharing.
स्ट्रोक भारत में मृत्यु का दूसरा सबसे आम कारण है। भारत में हर साल लगभग 1,85,000 स्ट्रोक होते हैं। जिनमें लगभग हर 40 सेकंड में एक स्ट्रोक होता है और हर 4 मिनट में एक स्ट्रोक से मौत होती है। यदि हम विश्व स्तर पर डेटा देखें तो हम में से 4 में से एक को अपने जीवन काल में स्ट्रोक होगा और उनमें से 90% स्ट्रोक को उच्च रक्तचाप, अनियमित दिल की धड़कन, धूम्रपान, आहार और व्यायाम सहित कुछ जोखिम कारकों को संबोधित करके रोका जा सकता है। उत्तराखंड के रहने वाले राजकुमार को 2 बार दिल का दौरा पड़ चुका है। आइए उनकी बात सुने।
कब शुरू हुआ था? जब आपको सबसे पहला हुआ वो कब हुआ? फिर
सबसे
आपका
पहले
छल्ला कब
2002 में हुआ जी।
अच्छा।
और जो ये साथ में दर्द, पूरा कमर में दर्द, गर्दन दुखने लगी।
हाँ।
फिर मैं गया, उसके डॉक्टर साहब थे उनके पास, वो थे नाड़ी वाले।
हाँ।
उन्होंने कहा, जब चेक किया उन्होंने तो उन्होंने कहा भी ये नहीं है, वैसा दर्द नहीं, गैस घूस का, आप अच्छे हॉस्पिटल में जाओ।
अच्छा।
फिर मैं अच्छे हॉस्पिटल में गया,
हाँ।
वहाँ दिखाने पे तब पता लगा, उन्होंने चेक चुक करा।
हाँ।
फिर कहने लगे भाई ये तो आपको हार्ट का अटैक आया है।
हाँ।
फिर एक इको टेस्ट था, वो टेस्ट किया।
हाँ जी।
तो टेस्ट करने के बाद में उन्होंने पक्का हो गया कि भाई हार्ट ही किया है और उसका आपका इलाज ही चलना है। मैं चलो ठीक है भाई, फिर वहीं लोकल में करवाया। फिर वहाँ से फिर आ गया फिर मैं यहीं, वो 2013 में।
अच्छा।
2013 में हुआ तो मैं ऋषिकेश से आ ही रहा था मैं, तो रास्ते में ही आ गया मुझे यहीं बाजार में स्टेशन पे ही।
क्या हुआ उस टाइम?
मतलब वो चक्कर से आ गया, मैं एकदम बेहोशी सी छा गई और सीने में दर्द। तो थोड़ा आराम कर लिया। उन्होंने एक गोली दे रखी थी, छोटी सी गोली के जीभ के नीचे रखने के लिए, वो रख ली जीभ के नीचे, थोड़ा आराम मिल जाता उससे। तो थोड़ा आराम मिल गया, फिर गया मैं उसे दिखाने के लिए।
तो वो गोली आप हमेशा अपने साथ लेकर चलते हैं?
ना अब नहीं, अब तो जब छल्ला डलवाया तब से नहीं दे रहा उसे।
अच्छा, तब से नहीं ले रहे?
तब से नहीं दे रहा उसे।
स्वास्थ्य संबंधी चिंताओं के कारण उन्होंने अपनी नौकरी छोड़ दी और अपने घर वापस आ गए। घर आने के बाद उन्होंने घरेलू कामकाज संभालने के साथ ऑटो रिक्शा भी शुरू किया। उन्होंने बताया कि 2 दिल के दौरे के बाद स्वास्थ्य संबंधी कौन से खतरे सामने आए।
फिर दवाई खाई भी ना, दवाई खाने के बाद में अपना थकान सी हो रही थी थोड़ा, मैं लेट जाता हूँ, आराम, काम धंधा कुछ था नहीं। वो लेटे लेटे में मुझे को हो गया।
क्या हो गया आपको?
मतलब मुझे कुछ पता नहीं चला, मुझे पता तभी लगा जब वहाँ पहुँच गए
अच्छा,
ऋषिकेश।
आपको किसने देखा?
तो ये बच्चे ले गए मुझे उठा के।
बेहोश हो गए?
हाँ, वो एकदम बेहोशी सी छा। मतलब ये तो अभी अभी की बात है, तो ये मतलब ये 23 में।
अच्छा,
वो 13 में हुआ था मेरे पहले जो, फिर छल्ला डलवाया, उसके बाद ये 23 में हुआ ये। पिछले से पिछले महीने समझो।
That was a story of a patient named Rajkumar in Rishikesh who suffered from stroke because of uncontrolled hypertension. So we saw how uncontrolled hypertension could lead to some fatal incidences later in life. Now I would request Dr. Pradeep Agarwal, who is the co-lead, who is the main lead for the project Healthy Food for All, to kindly present a vote of thanks. Over to you, sir.
Respected Honorable Minu Singh Ma'am, Executive Director AIMS Rishikesh, respected R.K. Singh sir, Dr. Arneet from Punjab, and Dr. Gurman. From the AIMS Rishikesh family, we are really very thankful for you all for sparing a time and a valuable inputs and insight. Ma'am have been an inspiration for everybody, not only for AIMS Rishikesh, whole of the North India, taking up the initiative of telemedicine and starting with the drone facilities in the far-flung areas of Uttarakhand. Moreover, Dr. R.K. Singh sir have already elaborated a detailed outline of state initiatives for the hypertension medications. And sir, from AIMS Rishikesh, we look forward for collaborative efforts taking up drone DDs and accessibility of medicines of hypertension and other non-communicable disease in the far-flung areas of Uttarakhand. Punjab model, as under the leadership of Dr. Arneet and Dr. Gurman, have been a role model which can be replicated in pan India, And with the new initiatives of current government of India's in the form of health and wellness center or Arogya Mandir, and getting them connected through the accessibility of hypertension medicines. End game is, अगर हमने hypertensive को diagnose कर लिया तो दवाई देने की जिम्मेवारी हमारी बनती है, because we want to avoid the health catastrophic burden out of pocket expenditure that leads because of the uncontrolled hypertension, either in the form of a stroke or any other disability. With this, I once again thanks to everybody. Along with this, I would like to thank my team, Dr. Nandita, Mr. Arshdeep, and Mr. Ankur Bist for facilitating and coordinating this of the webinar. After this, we will be sending an e-certificate along with the collaborative efforts. Looking forward to all the members who would like to join this AIMS Rishikesh initiative for hypertension control and accessibility throughout the India. Thank you once again. Jai Hind, Jai Bharat. Thank you.